Good afternoon, everyone. I am Professor Vieillard Baron from Paris, France, and I have to give you this lecture about the interest of prone position in spontaneously breathing patient admitted for COVID-19 respiratory failure. I have no conflict of interest to declare. So as you know, and this is not specific from COVID-19 patients, receiving or requiring mechanical ventilation are two different things. And if you look at, for instance, in a patient admitted for respiratory failure related to SARS-CoV-2, you can see that the rate of intubation and invasive mechanical ventilation is very heterogeneous, from small rate, 29% here in this series from Wuhan, to at least 90% in this series of patients from New York City. So this is, of course, either related to the severity of the patients, or maybe, or probably, to different practices regarding the intensive care unit. If you look at the two strategies that are already debated right now, you have the first one, which is absolutely to avoid self-induced lung injury in this kind of patients because they have a huge drive response, respiratory drive, sorry. And you can see that to achieve this goal, maybe that early intubation could be the solution with preemptive mechanical ventilation and sedation, but with some consequences, as you know. And so you have another strategy which is discussed, which is absolutely at the opposite, to avoid ventilator-induced lung injury, and so maybe to propose delayed intubation. And this is in this strategy that probably doing a prone position in spontaneously breathing patient could be a good option, just to avoid or to delay the intubation and the requirement to invasive mechanical ventilation. And this is probably especially possible in COVID-19 patients because first, as you know, either this is still in debate, probably that these patients have a limited alteration in lung compliance. Here, this is not the lung compliance, but the respiratory system. And you can see that around half of the patient had respiratory system compliance above 50 millimeters per centimeters of water. And just be aware, as you know, that many of these patients had obesity or increased BMI, so probably that the lung compliance was not so altered. But you can see that despite this, let's say, preserved respiratory mechanics, you can see that the shunt fraction, the lung shunt fraction, is very high, and so the degree of hypoxemia is very high. And this is probably due, as we know now, by some alteration in perfusion with two things. The first one is the total absence of hypoxic vasoconstrictive effect, so no regulation of the pulmonary circulation. And the second thing probably is that you have angiogenesis and enlarged capillary vessels, so explaining this shunt into the lung. The second thing that could support the prone position is the fact that either when you have a severe disease, so in patients severely hypoxemic, you can see that the clinical tolerance is not so bad because only around 35 to 40% of patients here in this study had a shortness of breath. So this looks like very different from usual ARDS, with a much better clinical tolerance. And so we have a strong rationale for trying doing prone position in awake patients in this disease. So if you look at the literature, we may summarize things as follows. First, prone position in spontaneously breathing patients is feasible. This is the first small series published in the JAMA journal. You can see 24 patients outside the ICU, this is important, with mild to moderate respiratory failure, as the PaO2 at admission was 73 millimeters of mercury. We do not have the P-on-F ratio, but we know that the vast majority of the patient had oxygen delivery with a low flow. And you can see that more than 60% of patients tolerated prone position session for more than 3 hours. So this is feasible without side effects. The second thing that we know is that it improved the respiratory failure. And so not only the oxygenation, but also it decreased the respiratory rate. You can see here a small series, 15 patients, once again outside the ICU, with moderate respiratory failure, as the P-on-F ratio just before proning was 157 millimeters of mercury. Just be aware that it was not 100% a spontaneously breathing patient, as all of patients in this study had some respiratory support with non-invasive ventilation. And you have here before proning, during proning, and after proning, after the resupination. You can see the SpO2 changes, the P-on-F ratio changes, and the respiratory rate. So you can visualize the increase in oxygenation with a significant decrease in the respiratory rate. But as you can see, it was not maintained after the resupination. The third thing that we may maybe suspect or support according to this study is that maybe that prone position in spontaneously breathing patient may allow physician to do some triage and maybe to detect patient who will require a later intubation and invasive ventilation. And you can see it was suggested here in this 25 patient series outside the ICU, once again, mild to moderate respiratory failure. And you can see the oxygen supplementation was done only by low flow device. And you can see here that you observed after 1 hour of proning an increase in SpO2. So we refine the increase in oxygenation just doing the prone position. But what was interesting in this study is that you can see that in patients who reach an SpO2 at least higher than 95% after 1 hour of proning, the intubation rate was low, 37%, while in the other patients after 1 hour, the intubation rate was very high, 83% of patients. And so to summarize the results, this is probably the largest series that we have right now, published in the Lancet Respiratory Medicine, Lancet Respiratory Journal. And you can see 56 patients outside the ICU with moderate respiratory failure, as the P-on-F ratio in average was 180 millimeters of mercury. But you can see once again that it was not 100% spontaneously breathing patient, as indeed they were awake, but with some support, because they all had an helmet device to perform CPAP, or not all, 80% of patients. And you can see that in this study, the prone position during at least 3 hours was feasible in 84% of patients. So we find again these important results. You can see here the change in P-on-F ratio between responders, half of the patients, and non-responders, half of the patient. Just be aware that the response to prone position was just defined as an increase in the P-on-F ratio after resupination. So here SP2 compared to SP1. And you can see that half of patients has some sustained increased oxygenation, even very low after the resupination. And what was interesting in this study, at the opposite of the previous one, is that they did not find any difference in the intubation rate between responders and non-responders, around 30% of cases, while the response to proning was not defined as in the previous study. So, but the big question, which is not yet resolved, is can the prone position prevent intubation and modify outcome in COVID-19 patients. And I recommend you to read this very interesting editorial by Telia, Skatira, and Brochure explaining how we have to resolve this important question. This is something that we try to resolve, and this is not yet submitted, but from this large cohort that we published a few weeks ago, we did a retrospective multicenter study in 379 consecutive patients with pneumonia related SARS-CoV-2. And you can see that in this series, 10% of patients, so 40 patients, had spontaneously breathing prone position. The PONF ratio before proning was very low, 63 millimeters of mercury with a high respiratory rate. You can see that most of patients had oxygen delivery using the high flow nasal cannula, and only a few patients had CPAP. So it was 100% spontaneously breathing patient without any respiratory support except the high flow nasal cannula. You can see here the change in PONF ratio and the pH before and at the end of the proning strategy, which lasts in average 2.5 days. You can see increased oxygenation and decreased pH because of increased PaCO2. And you have the tolerance, and especially the hemodynamic tolerance, which was good during the first session. The respiratory rate, no significant change during the first session, and the heart rate, no change. So look at the main result. You can see that the cumulative incidence of invasive mechanical ventilation in the 40 patients who had spontaneously breathing prone position was 40% compared to 71 in the other patients, and the day 28 mortality was 10% compared to 28%. It was unadjusted results, of course. If you look at now after propensity score, the adjusted results, you can see no difference in the requirement to invasive ventilation and to the survival probability in the two groups. So, which is a negative result, but probably interesting just to say that no deleterious effect. So in conclusion, there is a strong physiological rationale for doing spontaneously breathing prone position in RDS related to SARS-CoV-2, especially because of a better clinical tolerance to hypoxemia compared to usual RDS. We know that spontaneously breathing prone position is feasible, increased oxygenation, could maybe select patients who really need invasive ventilation, is not deleterious on survival with the limit of small trial, and so maybe does not promote any self-induced lung injury, and could help managing in this situation the ventilator shortage because of the huge afflux of patients in the ICU. But of course, RCT is needed before definitive conclusion. I thank you for your attention.